Everybody refill your drinks, get your last plate of food, and we're going to have the great pleasure and honor this morning listening to our guest speaker, Dr. Stephen Silberstein, Professor of Neurology and Director of the Jefferson Hospital Headache Clinic. And he will be talking to us about treatment options for migraine and headache, and he will take our questions. So you are now in a room with Dr. Stephen Silberstein with the best hat I've ever seen him wear. And thank you, Dr. Silberstein.
You're more than welcome. I sometimes remember what got me into headache. I was a general neurologist at a community hospital. We had a physical therapist down there who had intractable migraine. Once a week, the entire physical therapy department would stop working and to administer to her needs. And here I was, a smart-ass neurologist, and I couldn't do anything about it. So that was one of the things that got me interested. And then I looked around the city of Philadelphia, and there was nobody I could send her to. So I said to myself, we have a major need, nobody knows what they're doing. And then I got invited to give a talk on migraine because the person who organized the talk couldn't get anybody else to talk about it. I'd led a publication in the American Journal of Medicine. And then we said, you know, we have all these tough headache patients, let's try to do something about it. And a group of us were there, and then later on, Dr. William Young came aboard. And it sort of grew spontaneously, and then about 20-some years ago, we moved to Jefferson, and the rest is history. I remember when we started, there was only one company that had interest in headache. They don't even exist anymore, named Sandoz was the headache company, and we had DHE, Vagal, ergotamine, and 5 different formulations in Sansard. That was just about it. Then we had the era of triptans. Then we had companies that started to invest in preventative medications. And I would say things have been pretty quiet until the last year or two. And why? Sometimes when we think of what migraine is, it leads to new treatments. When I grew up, migraine was a vascular disorder. The aura was due to vasoconstriction, headache was due to vasodilatation. We invented drugs that constricted blood vessels. And by accident, the biggest accident of all is sumatriptan was developed based on its ability to constrict a vein in a dog. By pure accident, it had the same receptor that was on neurons. So a false premise led to a good drug. And over the course of the years, we've learned that vasoconstriction and vasodilatation don't have much to do with migraine. What we've learned is migraine is a fundamental brain disorder. And we look to the future, why do people get migraine? And what we think is the system can be turned up and turned down. So we have now a lot of good new drugs. There are companies that have taken old formulations of topiramate, made them long-acting, so there are less side effects. There are people that have reformulated sumatriptan in an easy-to-use format with lower doses with less side effects. We have companies that have worked to develop botulinum toxin for the treatment of migraine. That's where we are. And now we're getting devices. Why do we need devices? If you're pregnant or older, you don't want drugs to interact with you. And now the FDA has approved the cephalic device, which you may have seen, the transcranial magnetic stimulator for migraine, the vagal nerve stimulator for the treatment of cluster headache. That's where we are today. But where are we going next? And let's think about it. How do you proceed to make a new drug for migraine? The basic premise is, what is migraine? And as long as you're looking at blood vessels, we've gotten nowhere. So a number of friends and acquaintances started to say, let's look at some of these things. What can we talk about? So the first thing they started to do is look at things that could trigger migraine. Nitroglycerin, alcohol, and then these fancy compounds called CGRP and PACAP. And what was interesting is Unlike nitroglycerin where you get immediate headache, these compounds took a while to build up. What does that tell us? It's not really turning it on, but it's like with music. You turn the gain up so you get more response to what's going on. And based on this, we had a series of drugs called GPANs. These were small molecules that antagonize the CGRP receptor. What does that really mean? You have a chemical that does something to turn the system up. You block the chemical, and it no longer has that effect. And these drugs were dropped because of some toxicity problems, but there are new GPANs coming to the market being developed. And why is that important to us? The triptans have contraindications, cardiovascular problems, other problems, stroke, heart attack. This new class of drugs will not have those. So if they pass the safety issues, which I think they will, we're going to have a whole new class for migraine treatment coming down the pipe. There's another drug being developed, which is a cousin of sumatriptan, which doesn't have the effect on the blood vessels. That drug may be available soon for those of us who get older who cannot take the drug. What else is happening? If you watch television any night of the week, I swear to you, you're going to see 5 advertisements for antibodies. For everything from arthritis to psoriasis to God knows what. Guess what? That's where we're heading with headache. Major pharmaceutical companies are creating antibodies for that same compound we talked about called CGRP. And again, CGRP is the thing that turns up and turns down the volume. So the idea is to get an antibody, which lasts for a month, and basically dampens the entire system. The other interesting thing about the new migraine drugs, if you take a standard preventative, you have to take it for a while before it starts to work. What we've seen with these new drugs is you get a benefit within a week, and the benefit is long-lasting. So we're ending the era of drugs based on blood vessels and moving to drugs that are based on the physiology of migraine. Now, when I watch television, what do I see about antibodies? They scare me to death. You can get tuberculosis, you have to be tested for it. You get influenza. And they say, I don't want an antibody. But here's the point. An antibody is a tool. And all those side effects are for what the tool was designed to do. So those drugs interact with the immune system. The new antibodies are clean. They don't do that. And we're dealing with a whole new drugs, for all intents and purposes, have minimal, if any, side effects, long-lasting, and efficacy. And we're all looking forward to the next generation of new drugs, the monoclonal antibodies against CGRP. And following that, there'll be monoclonal antibodies against PACAP. So we're really entering a revolution in the treatment of migraine. For those of you who've given up, those of you who think there's no hope, I see more drugs in the pipeline being developed than you can imagine. Oxytocin, the love hormone, the cuddle hormone, is being developed for the acute and preventative treatment of migraine. The only side effect, that is, you get very cuddly after you take it. And there are a lot of other things that are coming down the pipe. So I'm going to stop at this point in time, and I will talk about and answer questions about anything you'd like to know about. Just stand up and tell us what you want to know. Stand up.
Hi, I'm Tammy. I've had migraines since I was 30 years old, so 9 years now. I'm interested to know, doctor, what in addition to the new drugs down the pipe is coming our way as far as being a patient at the Jefferson Headache Center? How far away is it from being a more integrated center for health, where biofeedback is maybe made more prevalent, as well as some non-drug options, maybe an acupuncture room? Just in my own experience, as I'm sure a lot of us can probably agree with, I've been on every drug you can imagine. I've been hospitalized. I've had nerve block injections. I've had Botox injections. And yet for me, it seems there's no better cure than meditation, yoga, a piercing in an acupressure point, and removing stressors out of my life.
We are one of the few headache centers in the United States that have psychologists and psychiatrists on staff. and we offer biofeedback. In our inpatient program, we actually have a class in yoga. The psychologists are teaching meditation. The problem is not that we don't offer it, but here's the problem. There are probably 36 to 40 million Americans in the United States. And as Dr. Young pointed out to me, there are more players in the National Football League than there are headache doctors in the United States. But the problem is not that we don't want to do it. The problem is resources, and thanks for Miles for Migraine and the efforts we're trying to do at Jefferson, we're trying to expand. We're trying to add one or more attendings and more psychologists as we move forward. The problem is not so much that you're wrong, the problem is you're right, and we're trying to do everything we can to do it. We're talking about a day hospital where people may come spend time and spend a lot of time doing all the non-pharmacologic stuff. We're the only people in Philadelphia that I know about that has integrated non-pharmacologic treatment in their program. It's not that we don't do it, it's the limitations in the world. Sure.
Hi. When you say the drugs are coming down the pike, how far down the pike? So these
Spring
are,
of next year.
okay, spring next year. If
Spring
that's-
of next year will be the first, and probably the fall will be the second of these new drugs.
And then how soon will before they'll be covered by insurance? Because once a new drug comes out, we're told about them, but then they say, well, but it's
Well,
not covered by your insurance.
Dr. Young is going to Congress all the time, and one of the things with your advocacy, they're not going to listen to us, but they'll listen to you. You talk to your congressmen, you talk to your senators, you tell them you have things that are important for you. Let me think about it. You see these advertisements on television for monoclonal antibodies for a skin rash, psoriasis. Is that as bad as migraine? No. What do you think that costs a year? Anybody want to guess what the monoclonal antibody for a skin rash costs a year? Anybody want to guess? Guess, give me a number. $45,000 a year, and it gets approved. The cost for the migraine drugs will be a fraction of that, but we have difficulty. Migraine gets no respect. We had a president of the United States or a first lady with bad incapacitating migraine, it would change. We did. The Senator McCain's wife with migraine and got very much interested, but we need to push. And we need to fight, and we need to fight for you, and you need to fight for yourself. Questions about anything? I don't bite. Bill?
Are there new formulations of botulinum toxin coming?
Yeah. As you're aware, botulinum toxin was used clinically to paralyze muscles. And basically, the way it became involved in headache is dermatologists who are using botulinum toxin to get wrinkles noticed that their patients stopped complaining about migraine headache. And basically, the old days were the muscle contraction, you relieve the muscle contraction, and that's how you get rid of the headache. But now we know that botulinum toxin really works by going into the same pain nerves that some of the other drugs affect and quiet them down. For that reason, new toxins are being made that only go to sensory nerves and not motor nerves, so there'll be no chance of paralysis or eye drop, and those are now getting ready to go into clinical trials. There are other toxins that last longer and shorter, but I think that the biological approach to all medical disorders is amazing, and you'll see more and more of it. I would suspect you're going to see more in the next 5 years than you have in the last 15. Sure.
Hi, I'm Margie. Thank you for all the work you've done. I'm not quite sure how to ask this in the correct way. Nobody in my family had migraines at all, no history that we can tell, and I have migraines and my daughter has migraines, and I'm wondering if there's any work towards finding out if my children's children might have migraines, things like that.
So the question is going to be, why do some people have a family history of migraine, and why do some people not? The question is complicated Because for some types of migraine, like familial hemiplegic migraine, we have one gene and we can track it. For most types of migraine, we don't have a simple answer. And what we actually believe is it may be a combination of genes that lead to migraine. And by chance, you may inherit one from your mother, one from your father. The combination comes into you, predisposes you to migraine, and you're more likely to pass it on. And it's very complicated, but it looks real. So it looks like that migraine is not a yes or no, but a maybe. This gene may give you 20% more, this gene may give you 20% more. You put a bunch of them together, you're more likely to have migraine. That's probably the reason. And they do some funny studies called gene-wide association studies, which is the technical name, where they take a population of hundreds of thousands of migraineurs, compare it to a population of hundreds of thousands of people with no migraine and no family history. They look at the genes and how they differ, and they're beginning to find differences. That's what's happening. And someday we'll be able to tell which gene does what. We'll know what the gene product is, and we'll be able to develop a drug to reverse it. That's where we're heading. Please. It's called personalized medicine, and it's happening in the headache field. Sure.
In headache medicine, traditionally, we don't use opioids. And some of my patients are asking, Percocet is working for me, why you don't want to prescribe? Maybe answering this question is important. What do you think? Should we utilize a little bit or none?
The question is opioids and headache. I always say the reason we have an opioid epidemic is we're treating a symptom of a disease and we're not treating the disease. So patients get opioids for all kinds of pain as opposed to drugs that are specifically benefit pain. But the problem with opioids in pain is worse. Forget about addiction. If you take opioids, you get something called opioid-induced pain. The opioids destroy your brain cells that control pain. And patients on long-term opioids develop increased pain and a worsening of their symptoms. So it makes it eventually impossible to treat. There are exceptions to every rule, but in this day of the opioid epidemic, there has to be a good reason to use them. Now, we have exceptions. If you're a pregnant woman, there's very few things that are safe and we're willing to use them. If you're very old, like me, and you have cardiovascular and you don't have those new drugs yet, it's not unreasonable to use it. And I don't totally ban it, but I will say that I like to limit it to several tablets a month. Once it gets beyond that, the problem. You know, if you take triptans daily, you wind up with a daily headache. But usually when you stop it, you get back to baseline. If you take opiates all the time, you may never get back to baseline. And that's the reason. It's not that I don't like opioids. I don't like what opioids do to the brain. Questions about anything? Sure.
Wait. Good morning, Doctor. Thank you for speaking to us today. My name is Tom. I live in Philadelphia. I attended the Cluster Busters conference 3 weeks ago in Chicago and met some wonderful people there who gave me a lot of information that I didn't have before. We had a lot of presentations, and we kind of found out that we're cluster heads, and I'm a chronic, 50 years worth of this stuff, just about every day. We found out that it's kind of like you fix your own car. We've come up with our own ways of coming up with fixing things, and one of them is we found out about oxygen. We had a demo, and we found out about the psilocybin, which seems to work for some people, which illegal drug. What I wanted to ask you, is there anything that you know about on the horizon in terms of a drug for people that got daily cluster headaches?
Absolutely. The same antibodies, this is miles from migraine, but cluster's the first cousin. The same antibodies that are being used, these monoclonal antibodies against CGRP, are currently in clinical trials for cluster headache with dramatic results. One shot and eliminates it. It looks that way. It's early to tell. Number two, the vagal nerve stimulator, which is now on the market, has now been approved for episodic, and there's some evidence taking it frequently might work preventatively for episodic and chronic cluster headache. And we're currently doing a trial in patients with cluster headache with a neuropeptide in the brain. So we are currently doing 3 or 4 cutting-edge trials in the treatment of cluster headache. So there is a lot of hope in the future. Bill, weren't you with Cluster Busters recently?
Yeah, I was at
Stand up.
I was at the Cluster Busters meeting, and I was very impressed by the spirit of the group and the willingness to do anything at all and to advocate for their disease and to do things to make themselves better. Good group.
Sure.
I'd like to speak in 2 questions. What is known about the long-term effects of being treated with Botox for migraine? And what can you say about what might be known about treating migraine with marijuana? And what are the limitations that exist to studying that treatment for migraine?
Excellent question. We're very lucky with Botox. Botox has been used for years for other indications. And there's absolutely no long-term problems with the use of the right amount of Botox. So that basically you can be quite sure that Botox is given for long terms. The major advantage of Botox, it stays where you inject it mainly, and the Botox itself is gone. But the effects of Botox persist for months. And there's no evidence that I know about that taking Botox long-term has any significant effect. We know for patients getting significantly higher doses for dystonia and other problems with muscle spasms. So that's good. Number 2, here's the fundamental problem. You may or may not know in the state of Pennsylvania, there's been legislation passed allowing the legalization of medical marijuana. In preparation for that, in order to do that, the places that dispense it have to have a partnership with the university doing research. Thomas Jefferson University is one of those sites. What has to be done is you have to create a course for physicians that they have to pass so that they can prescribe it. The problem with research in marijuana is the federal government. So even though states may allow it, it's almost impossible to go to the DEA and get marijuana for clinical studies. You can't grow it locally, you have to get it out of Mississippi. And they make it almost impossible to do clinical trials. But you may or may not realize that the body makes its own marijuana. Those are called endocannabinoids. And all the receptors and chemicals in the brain, they're more for the endocannabinoids. And one person has said endocannabinoids are the guardian of the synapse. They protect the brain. And there are now drugs being developed that can enhance the body's own endocannabinoids. And fairly soon we're going to be trials of patients with migraine where we can actually give them a drug that increases the body's own endocannabinoids and try to get them better. I think it's an exciting new field that's only limited by the super federal government. Questions about anything, please. Stand up.
So, my name is Rick. I'm actually the husband of your MC, Lisa. My background is in primary care. There's a few of us in the room at least. You already mentioned there's a big problem in that there will never be enough headache specialists. And in fact, general neurologists may or may not have the interest to work on this, and there aren't enough neurologists around either. What's happening in the headache community to broaden the range of skills of the primary care community to extend the work that you're doing to be able to reach everybody that needs it?
Well, we're approaching a revolution. One of my friends from Copenhagen and I and Bill Young spent some time together in Vancouver last month. And in Denmark, they have a course called the Headache Academy, where they take all comers, including nurse practitioners, physicians of all stripes who have an interest in headache. And this course is online and live, and it prepares people for certificate headache education so that people who are general physicians who do not have time to do a fellowship can develop an expertise. And as part of this program we're developing, it will give all of the people in the program direct access to us to come to us nationwide. So there's no way we can train enough headache doctors, but clearly we can train enough physicians in the basics of headache so they can better take care of their patients and be part of our network.
I had a question about the daith piercing in the ear. What people thought about it. I've read some online.
Sorry, can you say a little louder?
The daith piercing.
Which?
Daith piercing.
Oh. It's very difficult in a scientific way to control for a piercing. So what I'm saying is there's good scientific evidence that pain in one part of the body through a brain system can eliminate pain from another part of the body. Best example, if you stub your toe and you rub it, the pain goes away. And for example, the TENS unit that we use, the cephalic device, works in part for that system. And there's absolutely no reason why a piercing cannot do the same thing. So I don't know if we can prove it. I don't think it doesn't work. I can't prove it does work. But companies are now developing things that might be alternatives that work in the same principle. We're currently doing a study now of a device that sits in your ear, warms it and cools it, activates the vagus system, and may be good for prevention. We're moving a long way to where we were in the past. We're trying to get there. With a lot of things out there, the absence of evidence doesn't prove it doesn't work. That's one thing you need to know. So we don't know a lot about anything. We know a lot. We know a lot about a few things, and most of the things we don't know. And we have to be very pragmatic as long as it's not harmful. And it doesn't cost you an arm and a leg. That's the point. I've seen people get surgeries where they've out of pocket paid $20,000 or $30,000 and it hasn't helped. I object to that. But I don't object to trying something simple that's economically viable and safe.
Did you already address, I just wanted to recap, did you address acupuncture? Because that piercing deals with pressure point.
Acupuncture works. There's good evidence for it. The Germans have done lots of studies. I don't have a complaint about acupuncture, but you have to go to somebody and have them do something to you, and it costs money. It's not reimbursed. My bias would be save that for last resort and spend time doing meditation, yoga, relaxation breathing, because that's something you can do for yourself. So I prefer people to learn to take care of themselves rather than have somebody doing something to them. That's just my personal bias. If you're on vacation, you get a headache, you can't get acupuncture, but you can relax, you can do meditation, you can do yoga poses, you can do biofeedback. So I want you to learn something to take care of yourself. If that doesn't work, I have no problem with acupuncture, but the issue is you have to go to somebody, and probably by the time you go there and come back in 3 or 4 hours out of your life, whereas if you sit down on the mat and do your yoga, it's only 30 minutes. That's my problem. Nice, thank you. If you have some private questions, I'll be here.
Clap it up.
Okay, that was amazing because I actually learned something new. So thank you, Dr. Silberstein. Conclude by just really, I have to reiterate one more time that when somebody talked about is an insurance company going to pay for the new treatments coming on the market, I think that when we come to events like this and we begin to make more noise like we're doing today, we show up next year and every year and we come to the education day we'll be having in March, the public's going to start to notice, they're going to take us more seriously, and that's how we're going to get new treatments paid for. That's how we're going to get more funding for research. And I just want to thank you all for being here today. I don't know about you, but I have a migraine. So raise your hand if you have one too. So, thank you, everyone. Have fun.
Nice.